Welcome to TrulyFit, the online fitness marketplace connecting pros and clients through unique fitness business software.
Dr. Blair, thank you so much for joining the TrulyFit podcast.
Thanks for having me.
Why don't you give the listeners and the audience a little background on who you are and what it is you do in the health world?
Okay, so I am a licensed clinical psychologist. I'm a PsyD, and we'll talk more about what that means exactly. But I live in California from New Jersey, as are you. I moved to California about 15 years ago and got a master's in counseling psychology. I had already had a bachelor's in psychology and philosophy in New York City. Anyway, came West Coast and really didn't know it even at the time that this is a huge mecca for mental health in the treatment world especially. So I work a lot in addiction. I did a lot of my clinical training in treatment centers, working with dual diagnosis, which means a substance use disorder and a mental health disorder. They tend to go together, right? Especially if we look at substance use as a symptom. That's that. I've been licensed for just over 2 years. I've maintained a private practice at the moment since being licensed. And yeah, a mother of two.
And full disclosure here, Blair and I have known each other our entire lives. Since we were running around in diapers together. So so it's exciting for me to do this because I don't always get to do these things with, people who have good things to say, but also that I've known my entire life. So yeah.
Exciting.
Well, so I want to go back to something you just said because I had never really thought about this, but is it just because of the weather specifically, or is it because of the type of population, or there's more physicians out there? Why is there such a large clinical setting for those sorts of things in California?
Great question. I think a lot of it does have to do with the weather, which seems so just whatever, but truly part of mental health and wellness is leaving where you're from, where your family, your support system. And if you're going to do so, why not do it in a place where you can engage in hiking, outdoor activities? There's so much evidence showing how sunlight and physical activity, being connected to nature, an ocean view makes me smile for sure. So yeah, I do think it is very much like that. And there's also a cultural influence. California, I feel like, has been talking about self-care, kind of spearheading that conversation in this country. Coming from the Northeast, I still struggle with self-care being just go to work, or get over it or whatever, strap up your boots and just figure it out because the clock's ticking.
And I don't know if it's a northern thing or like a population thing, because we're so where we grew up is the most populated state per square mile. And you feel like you're always fighting for something. I'm fighting to weave into traffic. I'm fighting to be first in line because I can't wait. And there's just this we have to go, we have to get it. And
that's right.
And because of that, unfortunately, people aren't as nice because that's just the way of life. So
yeah, I heard a funny thing when I first moved here that people in California might open their arms to everyone. This is such a generalization, okay? So just whatever, but just to give you an idea, is that they might open their arms to everyone, but they can't really, wrap all the way around. Where someone in New Jersey is not going to open their arms to just anyone, but if you're one of their people, they will wrap around you so hard, watch your kid, move your sofa, show up for you, whatever you need, bada bing, bada boom, we are there. I
do think that's the case. And I've seen that with even cities like Chicago, and I don't know what it is. I don't know if it's, I hesitate to say it's like the Italian Irish thing. I really do think it's maybe just more of the, once we trust you, you're in. We love you for life, but we're in a rush and we got to make sure that you're on our team and you're helping us get to what we need to do.
Exactly. So I would imagine that has something to do with it.
Is you touched on it briefly, but can you go into depth on the differences between your degree and a psychiatrist and a psychologist and the different levels of them, because the general population just doesn't know?
Sure. So psychiatrist is a medical doctor. A psychiatrist has gone to medical school, can prescribe medications. Okay, so they are in a league of their own. And in fact, anytime someone's really presenting with a mental health diagnosis that requires any sort of psychopharmacology, anything, it is crucial that individual be referred to a psychiatrist, the medical doctor. Okay, so there is an importance of staying in your lane, so to speak, in this field and knowing your scope of practice, working within it. And if something presents that's outside of that, knowing when to pass the baton, so to speak, and even better, sign a release of information that would allow some collaboration between providers is really can help treat the whole person.
Is your, sorry to interrupt, but is your like patient experience typically people who seek you out, or are you referred by another physician or somebody else in the medical community?
Yeah, so I have been referred, having worked in treatment centers, upon discharge, if someone's completed treatment successfully. So in other words, not left against medical advice, but has really, it's deemed safe to be treated on an outpatient level of care. I've received many referrals, almost all of them from treatment centers that I've worked in.
Gotcha. Yeah, it's interesting to know like how that's interconnected. I know, you know, from my wife as a pediatrician, that at least here where I'm located, it's difficult to find people who do what you do, especially on the pediatric level. So people are waiting sometimes months to see somebody before they get in, and sometimes you don't have the option to see a psychiatrist, and even if that's what you have to do, so then they'll send you somewhere else. So do you get what you would say like overflow as well?
Sure. Well, especially when it comes to substance abuse, you're really dealing with a level of safety. So there's some real critical and medical necessity for someone to be in an inpatient versus an outpatient level of care. So this is unique in that sense. But even, you mentioned child psychology. I've worked with someone who said, I'd really love my 15-year-old to work with you. And I just don't do kids.
Yeah.
And then especially so a teenager could have some challenges that we might be able to address in an adult manner, but still that would be me staying in my lane and finding someone to refer to. But then imagine what an 7-year-old, that kind of clinical intervention is so unique and delicate and not to be practiced flippantly. Right. I'm not going to open a manual about how to work with kids. I mean, that is a specialization. And because they're few and far between, it can be really frustrating to find someone.
Yeah. And I imagine not just because of the actual sort of psychology, the mental side, but because of anecdotally, it's good to have seen a certain amount of a type of patient, because things repeat themselves, right? So if you're seeing these patients over and over and over, you have a little bit more anecdotal data on how to deal with things. But if you don't see kids, then you're not going to have that necessarily.
Sure.
But in the personal training world, unfortunately, it's funny. The higher you go up, it seems, in education, the more people stay in their lane, and the more they understand. Nope, this is only what I do. My wife is the same way. She refers out all the time. But in what we do in the certification level stuff, people think they can do everything, right? It's like, I want to lose 30 pounds. I have you. I want to gain 30 pounds. I got you. I'm going to go up on stage and bodybuild. I have you. So I try to work with personal trainers to say, eventually, if you really want to be effective, you have to niche out and start to learn about one particular thing so that you see it over and over and over, and that you can help people.
Absolutely. And even ironically so, in the mental health field, the lower the degree, the more critical of cases you're dealing with. When I had a bachelor's in psychology, my first job in New Jersey was dealing with dually diagnosed adults, which was not just substance use disorder, but mental health. I'm talking severe schizophrenia, major mental health diagnoses with minimal training. And it seems kind of backwards. It's counterintuitive, that's for sure. Yeah,
for sure. You mentioned addiction. That's one of your specialties that you work in.
Mm-hmm.
That's an umbrella term, obviously, but does the clinical community, or you can speak to yourself if you think differently than the community, see all addictions as somehow interconnected? And I could just expand on that a little bit. If I'm addicted to gambling and Bob is addicted to alcohol, do we have some sort of inter-issue connection, or are these things completely separate?
Sure, I would say there's an interconnection. I would say that really, to simplify it, it's like outsourcing our self-regulation. So it's using something outside of us to regulate some sort of internal process. So that could be gambling, that could be shopping, that could be sex, that could be food. Any process addiction would fall under that, right? It's serving some sort of function, whether it's to feel nothing. So that could be more of your numbing. It could be to feel something. Some people want to feel something. They want a thrill. So even within gambling, actually, my first internship at an amazing facility in LA called Beit Teshuva had a gambling program. And even within the gambling, they tend to separate the action gambler, which tended to play craps and like more stimulant drugs, from the escape gambler, who was kind of like, what we were seeing was like middle-aged women who would sit behind that slot machine for hours. And even the casinos could play on the loneliness that may come with empty nesting or with whatever that could be going on during that life stage. And they'll repeat your name. Well, welcome back, Patty. And have a whole different function within gambling in and of itself.
Yeah, that's really interesting. I had a period of my life where I was sports gambling. I don't do it anymore. Not that I was considered addicted by any means, but I started enjoying the sports less when I wasn't gambling on them. And to me, that was the issue. It's like, okay, I'm at this game, and like if I can't bet on it, it's not as fun. So I just saw that could potentially be a problem, and pretty much just cut it out cold turkey and said, this is not worth it, because I'm not enjoying watching sports, and like I don't want to be at my my child's softball game thinking that I have to have $20 on the blue team.
Right. Well, well, congratulations, you, sir, are not addicted. So basically, that could bring us to what even like addiction is, right? Or how it's diagnosed. What are the diagnostic criteria?
Yeah.
Because quantity of consumption doesn't necessarily define addiction, right? We mentioned Italian Irish cultures earlier, and not even to throw out stereotypes, but in a way, it would be totally normal to have a glass of wine 7 days a week with food, whatever, in an Italian culture, for example. So it wouldn't be like, how many glasses of wine a week do you have? But rather, are there negative consequences in your life? So for you saw something, this isn't fun, so I'm going to stop. So if it started affecting people's relationships, mood, ability to function at work, increased tolerance, which would then therefore imply like some sort of withdrawal if the substance wasn't had. Now we're getting into real problematic usage, right?
Can you be addicted to anything then? Because I can think of a plethora of things that would fit into that category. Like, so, and I don't mean like just from the general sense, but I mean actually diagnosed. So can I be addicted to video games? Can I be addicted to, which gets into the next question, can you be addicted to fitness?
Certainly. So that all of those that are not substance use would be called a process addiction in the DSM, the Diagnostic Statistical Manual. So that's called a process addiction. So certainly all of those things. Fitness is one that you see people transfer. So there can be a transfer addiction. I've seen people stop drinking alcohol and then gain 50 pounds, if it goes to food, or transfer to gambling. Yeah. Or, I used to do heroin. I don't touch this stuff. But isn't $30,000 worth of debt due to a shopping addiction, right? So if coping skills are not improved, right? So if there's not insight into the underlying motivations to have this sort of behavior, then we can see it like the pressure bubble, just kind of like, it's like whack-a-mole. You hit one and that goes down, but then something else pops up, unless you're doing more treatment for sustainable change.
Yeah, I've actually worked with a handful of clients. Again, it's above my pay grade, so it's not really like I could step in and say anything, but they were addicted in the past to something. Not immediately had come to me. Maybe it was 3 years later, 10 or even 10 or 15 years later, but you can tell they still had, again, I'm not trying to sort of pigeonhole anyone, but an addictive personality. And they came into fitness and they only wanted to do they need to run ultra marathons. They couldn't just take it easy, or they wanted to go up on stage and be a bodybuilder and had to take it to the next level. And I started to see some self-harm in those areas too, where they were doing all the wrong things to get to where they wanted to be, and sort of masquerading it as health and fitness.
That risk is there, right? There are certainly personality traits, as you mentioned. Especially in early recovery, if you think of someone who just came off of years of utilizing a substance, outsourcing their self-regulation, and now they're just kind of, they're sober, they're really interested in achieving and maintaining sobriety. We know better than to think it's like, okay, just stop it now, right? So in my opinion, if you were to use that transfer addiction and direct it more towards fitness, in my opinion, exercise all day long.
Yeah.
If that's going to keep you from shooting fentanyl, which might not allow you to, see the next day, then personally, I would say go ahead and do it. Now, that's early recovery. Not to mention, let's say someone starts hitting the treadmill. You're going to start getting endorphins going. It's an incredible treatment for depression because of those positive neurotransmitters. It's also an incredible treatment for anxiety. So if anxiety is anticipation of a stressor, by getting your heart rate up and maintaining that heart rate, it can really help bring you back down to a homeostasis, more balanced. So I say by all means, not to mention self-esteem, right? People start looking better, feeling better. There's a lot of benefits.
Yeah, I'm with you. I mean, it's the lesser of two evils, I guess you would say, in that case, right? So you're at least transferring it to something better. And again, this is well above my pay grade, but maybe there is no opportunity for this person, or at least in a quick manner, to get from where they are to, let's say, the ideal, perfectly mental, healthy lifestyle. So they need to have some sort of progression.
Right. And does that even exist?
Probably not.
Right?
No.
Our ideas of perfectionism and the way people should be really seem to be changing. I know COVID has brought a lot of these conversations into the mainstream of what is normal and what is this and what is that. So in understanding the complexities of human behavior, exactly. Now you're going to run into some risks, right? So let's say someone starts utilizing performance enhancing drugs. That can get, can be a whole different level of unsafety, or even pre-workout. I've seen people in recovery just slamming these pre-workouts and they can't sleep. And so there's still some caution to be around it. If someone's running on an injury, that could be problematic. Like if their knee or something's telling them to slow down and they're not listening to that. I would say that's where your coaching would come in, right? And your expertise and your support.
I have a really good friend, Chris Scott. He's been on this podcast before, and I guess he doesn't call himself a recovering alcoholic, but from a general perspective, that's what he is. And he focuses on sort of the physiological imbalances that alcoholics have, which I find really interesting, because there is a lot of if you've been drinking, let's say, a handle of vodka every other day for the past 10 years, your body is now lacking certain things, right? You have your GABA, beta receptors are all off. Sure. And you haven't been sleeping well, and you've been obviously beating up your body. You haven't been eating, right? Because a lot of these alcoholics don't eat because they're spending their money on the alcohol. So he focuses a lot on that side, which I find is really interesting. And I hope down the road, there's more research put into actually helping not just the sort of you need to find Jesus, but you also need to heal your body from the inside.
That's right. Hydrate, right? Yeah. Liver enzymes can be way off. Absolutely. I find, I'm a data person at the end of the day. I love data. I'm comforted by it. There's a lot of obscurity and things that are abstract with therapy, which doesn't deter me at all. I'm ready to hop on that journey with people, however long it might take. But there is something comforting about the measurable, the quantitative.
Sure. And I think too, if I was in that position personally, I would want to know that this isn't just like me healing myself through like some psychological broken process, but that I could also either expedite it or it's sort of a 50-50 thing. Like, yes, there's also something wrong with me physically that I can help speed up this process. I just think that would be more of a, I don't know, like I would be not ecstatic, but I would be very happy to know that this isn't just me being broken, but that there are fixes there that are physiological that can also pair with my slow gaining back of that sort of mental psychological side.
Totally. And then you can have great benchmark workouts. You can see progress, really short-term attainable goals, whether that's a few pounds down, a few more pounds up on the weights that you're lifting. So that's nice too. It can really create momentum.
Yeah. So on our health history forms as personal trainers, we work with people, and I know, again, you've explained this on the front end that you don't prescribe medication. You are not, right? You're not a psychiatrist.
Correct.
But do you know of any, or do you see any issues when people are, let's say, off medication as opposed to on medication, things that you have to be like concerned with? Even, and you don't even have to let us know from like a personal training standpoint, but from like general population standpoint.
Medications affect people differently. So they really, really do. The one that I would really raise a flag with would be any benzodiazepine. So that's your Xanax. That's typically prescribed for anxiety. And we're talking like generalized anxiety disorder. Okay. So we're not talking like I'm feeling nervous about my job interview. We're talking like pervasive, disproportionate, debilitating anxiety. Sure. That's the person who would be prescribed this. Even I would say in the medical field, people are much more conservative about prescribing than they were, let's say 20 years ago, maybe even 10 years ago. We see this in our culture. We see this with opioids. We see this commonly, right? Sure. But benzos is one that I've just observed people a little lethargic, sure. Not necessarily sharp. Right. It also has a similar impact. It attaches to similar receptors in the brain as alcohol. So any benzo would be contraindicated for an alcoholic. So in other words, if someone has a propensity to get addicted to alcohol, any psychiatrist who's aware of someone's history like that likely would not prescribe that medication. So that's the one that comes to mind. As far as the antidepressants are concerned, it really would require self-report by the individual themselves.
Sure. Yeah. And it's good that you said that. Just, us as personal trainers, we have to do our own due diligence, unfortunately. If someone hands us in like a health history form and they're writing all their medications out, we have to then go online, research these medications and see like what are potential side effects, so that I know if I'm working with a client that something could be wrong due to the medication. So it's interesting. I've never worked with anyone who's on benzos, but I would imagine, like you said, if it has that alcohol-esque effect where you're more tired, then you have to be even more attentive when working with that client, because you don't know if they are, let's say, I don't want to say not paying attention, but the lapse in sort of like energy, is more subject to injury. So it's something you have to stay on top of, and that's a part of our job that's difficult, because again, it's well above our pay grade. But I've had issues with it in the past, because some of the medications, when we work past a certain point, let's say if I've changed their lifestyle completely.
Wow.
And, well, what I mean by that is like maybe they were sitting down all day long at their desk, and they never worked out and they ate like crap. And then 3 months later, now we're working out 3 days a week, and now they're eating healthy, and now they're getting up for walks to midday, right? Everything has changed. Yet, they might have, let's say, their cholesterol levels are still high, or their cholesterol levels have now lowered, but they're on Lipitor or something, right? So like the doctor says, oh, it's the Lipitor that's doing it. And I say, no, it's our lifestyle changes that are doing it. And that's an issue that we have as personal trainers, because we have to sort of fight that. Like, okay, is the work that I'm doing helping this person, or is it the fact the medication's helping this person? How am I ever supposed to know if they're not pulled off that medication? And I would imagine you have that maybe issue too. If you're working with someone who is depressed, let's say, and they're on antidepressants, and you've been working with them for 2 years. It's like, well, how do I know if my work has been doing the vast majority of the good, or if the medicine has been doing the vast majority of the good? Right. But and the point is, if someone's better, that's all that matters. Yeah. Right. Yeah. So what are this is the fun stuff now. Okay. We got that stuff out of the way. All right. What are some alternative treatments that are going on now, whether it's in, or experimental depression, anxiety, addiction, that you find intriguing? I'm certainly intrigued by the psychedelic world. Definitely not the population that I primarily work with. Would I ever recommend that? But outside of that, I'm certainly intrigued to know how perspective can really alter someone's lived experience. But as I mentioned earlier, as a clinician, I love data, right? So there's some really good stuff happening with technology. It's on our side. So I had mentioned earlier, there's brain mapping, also known as neurofeedback, where clients are hooked up. I want to say it's an EEG, don't quote me on that. And you can see activity in the brain and parts of the brain that might be less active. Let's say in the prefrontal cortex, where you have executive functioning. So that would be your ability to plan, play out the tape, so see consequences before they happen, etc. You might see low activity there in someone with ADD or ADHD. So it's certainly effective for that particular diagnosis. But part of the issues that we face with whether it's depression, anxiety, is this arduous process of trial and error of what works, what doesn't work. Whether it's the modality of therapy. So what I do, which is talk therapy, there's numerous modalities and approaches to that. Okay, so there's that. Then there's countless antidepressants if someone decides to take that route, which works for me. One of the most impressive things that I've ever seen in my 10 years, so it's really, I'm kind of a novice still in the field, which is exciting as a woman, right? The older I get, the better I'll be, is the genetic testing. So that you could do a whole blood panel to see which antidepressants are compatible with your genetic makeup, which is awesome. Because let's say it narrows down a list of 25 to 50 to 5. Okay, fantastic. Yeah. So with brain mapping, really what they can see is responsiveness versus non-responsiveness. So if you're taking a medication or engaging in some sort of talk therapy, whatever, and there's no change, you can pivot more quickly than going about something and trying a medication at different dosages, et cetera, for 6 months. Some of these medications, then you'd have to like slowly titrate down, which is like, again, it's frustrating. And people, not that a quick fix is the way to go, but the sooner the better, right? Let's spare people if we can. Sure. Another awesome thing is called TMS. Insurance does cover it. That's another thing with neurofeedback, because it's so measurable and a short-term treatment, you're more likely to have your insurance cover it. Great, right? So yeah. I was a program director at Passages Malibu, and I've worked at Cliffside Malibu. These are pretty expensive places. So while it's so wonderful to discharge someone with a plan that includes regular acupuncture and breath work and all sorts of providers, massage and psychologists, everyone, the average person can't afford that, right? We need to find things that will be covered by insurance. Again, so cost effective, time effective, and these are some of the things that are coming up that I think are going to help a lot of people. Well, that's great, especially from, we talked off camera about the sort of the subjective, objective nature of some of this stuff. So It's great that there have these tests that you can really see if the medication's working, number one, because you can get on the other medication that you need to be on quicker so that there aren't issues. Exactly. And then any medication, let's say it's a cancer treatment, when it's targeted and they're doing the research, then we know you're going to heal faster. So I think that's great. Speaking of what we talked about before, the psychedelics you mentioned, I know that they've been doing a lot of work with people with PTSD, specifically in the military. using both low-level psilocybin, but also MDMA. And they found great results. I know for years overseas in sort of like marriage counseling in the Nordic countries, they use low-level MDMA for, you know, a lot of healing processes that seem to be successful. I don't read the data. I don't have these long form things to look into. But as far as, again, just reading about the anecdotal stories and how it works and how the practitioners who use them are really pushing for it, it seems like it's just 5, 10, 15 years away from being the norm.
Fantastic. And really the way I operate is if it helps someone somewhere, by all means. So there's certainly some risk attached with those sorts of chemicals, but if it works, fantastic. And if it's done safely, beautiful. Years ago, there was a study done out of NYU with psilocybin, and this woman was a cancer patient and really, really depressed, right? So the motivation to continue with her treatments was really starting to, she'd had a lot of hopelessness around that, and participated in one of these controlled studies, and like for the first time noticed that there was even a plant in the room. She had been in this room several times, didn't even see the plant, and it connected her to the world around her, and it motivated her to continue doing the things that the medical doctors were suggesting, and the treatments that she was actually losing motivation for. I literally have goosebumps on my arms right now sharing that study.
Yeah, I mean, taking yourself out of your own body, so to speak, allows you to see things from afar and get away from those things. I know they have the similar research to people who were taking psilocybin who got over their smoking addiction.
Yes, eating disorders.
Because of the same thing that you mentioned, where they sort of had this experience where they were sort of outer body, for lack of a better term, and said, I don't need this. This isn't me. This isn't who I am. And one sees the self different from like a philosophical standpoint.
Yes, perspective. People with eating disorders, it can go from, disordered eating in general is eating with the mind, right? It's not eating with the body, it's eating with the mind. And something like a psychedelic experience can help people differentiate between that and have the self-love and the self-esteem to want to make positive change. And we spoke on the phone the other day, and I had mentioned self-esteem. I feel like at the end of the day, that's kind of what it is, right? When we have self-worth, we're worth the gym membership, we're worth the physical, going to the doctors once a year, just to be preventive and proactive about whatever. We're worth the relationship. We're worth asking for a raise. We're worth all of these things. So anything to get there, any path to that, by all means, in my opinion.
I'm with you. You're preaching to the choir here, and I tell a lot of my young personal trainers that I work with who like want to start a business and they're kind of worried about it. I was like, would you tell your significant other that they don't have the skills to do this, that they're not worth doing this, that they're not smart enough to do this, that they're not capable enough to do this? No. Why do you tell yourself that?
Right.
You wouldn't tell your partner that, but you tell yourself that. So like
you're our harshest critic.
You got to be kinder to yourself. And then also like, as far as the physical stuff that you just mentioned, like, investing time, self-care, we started the conversation talking about this sort of the self-care thing. People just don't do it. I mean, even like my wife was like, I don't want to spend, she's a doctor, $18 a month on this gym membership. I'm like, what? Like, you need, like, this is for you. You have to do this, or else you're not going to be ready to see your patients if you are not whole yourself. And I think people need to, and I don't mean this in a bad way, sort of like a used car salesman way, but we need to pitch that to our general population as personal trainers and as medical professionals to say to other people, sometimes you have to pay an expert to help you with your psychological side and your physiological side to get you to where you need to be.
Whole person, mind, body, spirit. And this is where stuff like self-care gets complicated. People can become paralyzed with guilt around that.
Yeah.
Guilt.
Totally.
I mean, so that's where the talk therapy comes in. It's like, well, who was modeling that? Who modeled that it's one shouldn't participate, and that actually doing so is selfish. It was a message that a lot of us have received. And it's worth exploration to see whose voice that was. Complicated. We're complicated.
It is. It's a blessing and a curse, double-edged sword. It's good to be our harshest critics sometimes because it pushes us to get to where we want to be in life. But at the same time, we have to look back and say, I'm only this age, I still have a lot more time to go, or, you know, this is only one day. I think people, and this works both in the fitness world and in the business world and even in the finance world, where people, you would never look at your retirement account every day and be like, oh, there's only 11,000 in there. The next day, there's only $11,003 in there. There's only $11,006 in there the next day. No, you look at it once every 6 months, right? But we look at the achievements that we have on a 24-hour basis and be like, you know what? I didn't get enough done today. I'm a shithead. It's like, no, it's you can't view everything from a 24-hour perspective. You have to give yourself a break and look at things. And that's a big problem with weight we have with clients is they want to hop on the scale every day, every other day, and view everything off of that particular number, when it's like, listen, it has to be more about how you feel. It has to be more about how your clothes fit. It has to be more about your health and your labs. I always say health is in your labs, not in your abs. And
I love that.
Yeah. And that's how we have to move forward. But it's a difficult thing. I don't expect people who don't think that way to change overnight. They have to work with people like you and make this a lifelong concerted effort to sort of change the way their brain is thinking about these things.
Right.
Do you, we didn't talk about this, but do you work or have you worked with people who have, I guess you would say, vanity issues, for lack of a better term, whether that's anorexia or bulimia or any of that stuff? Have you dabbled in that?
Sure. I have, and I would say vanity is probably on the bottom of the list about what that's about.
Oh, really?
Yeah, it really is. In fact, bulimia is, there's a lot more of dissociation involved with bulimia. Bulimia is not really even an effective form of weight loss. I think there's like an average of an extra 10 pounds on most people who are engaging in that sort of behavior. Anorexia is a lot of dealing with control, perfectionism. I see perfectionism everywhere, and so much with alcoholics. So much. There's so much pressure to be perfect, and this split sense of self of like, I have the side of me that presents well, and I have the side of me that like maybe whatever it may be doesn't look a certain way, maybe is attracted to people of the same sex, maybe whatever it may be, and we hide that side of ourselves. But being we're human, we can only handle that amount of pressure without needing something to soothe.
Yeah.
So perfectionism is one of the things I see most frequently. I see it across all socioeconomic, all cultures. It's there.
I wanted to ask you about, and again, this is something else just popped in my head. We didn't talk about this previously, but with social media here, and it's here to stay. It's not going anywhere. Right. It seems like we have three personalities now. We used to just have the Steve that presented itself to at work, maybe with his colleagues, and then the Steve around Blair and his friends. But now there's the Steve who's online, right? The Steve who presents himself as a character. And we've seen it. I'm sure we have mutual friends from high school who like present themselves online as these people who they're just not, right? Like maybe they were never funny, but like they try to be the comedian online. Is this, do you think this is an issue now? Are people like you dealing with this? Is it going to be an issue moving forward?
I think it is. I really do. I certainly see it with young people. I was working with someone this week. I'm an adjunct psychologist at Oceanfront Recovery in Laguna Beach down here in Southern California. And this young man who's 20 said, I went off of all social media 2 years ago. And my jaw like dropped, which made me feel like, wow, maybe I made an assumption that the Gen Z is like 100% across the board obsessed.
Yeah.
So that put me in my place a little bit, but I also was like slow clapping, like hell yes.
Heck yeah.
Because of all the things of the FOMO, of the this, of that, and the identity, especially for people coming out of high school who went to college, who didn't, what that looks like when people start getting jobs or having families, and a lot of the feelings that can come up when you see your peers doing things that you want to be doing and appearing to be this thing, right? So I'm sure we'll create this fantasy in the story about what we see. That is not helpful.
No. And I think people think they're motivating people when I think the data's out. That's not the case. We're seeing, especially females, young females, I think it's like threefold increase in self-harm. We've seen suicide rates through the roof. Now, of course, some of it's COVID, but it's really a lot of it is the social media burst. And people have asked me before, Blair, like, hey, Steve, how come we never see any of your workouts? Like, how come you don't post your workouts? And I'm like, well, again, I'm trying to make myself sound good. And at the same time, I'm making myself sound bad, but like, you can't do what I do. That's what I don't want to show you what I do because you're not going to feel good. You're going to say, I wish I could do that. You're not going to be able to do the things that I can do. Some of it's just genetic, right? Some of it are exercises that I've worked on for years to perfect my form, to perfect everything I'm doing, to show you a 30-second clip about what I'm doing. I don't think that's going to make you feel motivated to do that. I think it's going to make you feel like shit that you can't do that. So that's why I don't post the clips of me working out. And I don't think that's going to change. I think people lie to themselves and say, oh, I'm just motivating my fan base. I'm like, I think you're doing more harm than good.
Yeah. The statistics that came out with young people, I'm talking like 12 to 15, was extremely disturbing. And I'm a parent. You're a parent. I have two daughters, and I'm terrified, quite frankly. I really am.
Do you have a plan?
I'm hoping the bubble bursts. I don't know. Maybe it'll be illegal by the time they're of age. My girls are 3.5 and 1. But just briefly, my husband and I took our girls to this little lagoon locally towards the end of summer, and there was a 12-year-old birthday party happening. And we saw one girl take a picture of another girl in a bathing suit and post it. And the girl whose picture was taken flipped out, like take that down. And it had like a whole visceral reaction. And
there was no filter on it, and she didn't get to see the picture, right?
And she clearly didn't like the way that she looked in it. And it was really hard to watch. And it was very real. Yeah, it was real. There was nothing a facade about her emotional reaction and response and the way it affected her. So it's terrifying.
Yeah. I don't have an answer either. It's terrifying. I'm hoping that things sort themselves out between now and then, but it's probably unlikely. So us as parents just have to do a better job of
exactly. And we're adaptable. We've always been adaptable. I had to renew my license and do all sorts of psycho ed stuff, and which wound up being fun, expensive, of course, but fun. And they were going into the history of technology. And even when power steering came out, everyone's like, no one's going to know how to drive anymore. Well, like, who cares? Okay, it's totally irrelevant. We adapt. So I think we just need to stay really privy to what's going on, right? Yeah. And keep our awareness up and pay attention.
Yeah, I'm with you. I'm going to be on a podcast soon talking with someone. She's a registered dietitian about vanity versus health. And it is a big issue. Just, sort of like what we're briefly touching on now is that, people are masquerading what they're doing in gyms and with their bodies as health, when really it's just vanity, right? So some of these people are healthy. They're actually doing it as health, but health is a secondary effect of the vanity, as opposed to vanity being a secondary effect of the health. And that's really what I'm concerned with the social media, as far as like, I'm inundated with, obviously, and I'm targeted by the social media with fitness-based things. So I'm seeing these things all day long. And I know that if I'm seeing them all day long, then all these other fitness people are seeing them all day long. And I hope that they start to see them as I do, or start to tell themselves like, this isn't real. These are all filters. Everyone doesn't look like this. There's more to this. And I don't want my daughter involved in that. I don't know the answer. Maybe the answer is don't let your kids on social media until they're of a certain age, or just explain to them that this isn't real life. Right.
Hopefully it just doesn't have as much value, that it's there, but it's just not that important. Yeah. It's tricky.
So clinical guidelines taken away. Okay. Blair can do whatever she wants. It's they're all taken away in America.
Okay. No, there's no law-abiding board, no body to answer to.
Nobody to answer to. You're not going to get in trouble here. You have one change to make. What would you change? What would help either the population you currently work with, or someone else that you can think of that is dealing with issues within your realm that you think could make a difference that is just not there due to some like regulation?
I would have to go, and we've touched on this a few times already today, would be the strict HIPAA regulations, right? If I could keep in contact and have collateral information from someone's personal trainer, from someone's loved one, within reason, never a perpetrator, never someone who's harmed an individual, to see the whole person, I think it would be really effective. And I'll give you an example. Working in treatment and at treatment centers, my favorite part about it is that I get to work with a team. I get to. Private practice is a pretty isolated relationship between a provider. It really is. And not only do you not talk to people, but you can't. Now, the people that I work with out the gate, I do share that I love talking, especially to a psychiatrist. Like I need to. So I will request that someone sign a release of information. So, and let them know it is only out of your benefit. And I can even keep you posted on any correspondence. And if someone's unwilling to do that, that actually is a boundary that I would set, that I can't work with someone who does not want me working with their psychiatrist, because now I'm confused, right?
Yeah.
To see what that would be about. Maybe there's some medication seeking that the person hasn't disclosed to me.
Yeah.
But like at a treatment center, for example, you've got a whole team, psychiatrists, psychologists, but even so, people on the ground level that are seeing the clients, the individuals, from the moment that they wake up. So there was one client in particular who I was in a clinical meeting and presenting the case and speaking about how well he presents. And they were like, no. Aside from going into session, we can't get him to make his bed, to get out of his pajamas, to do any sort of ADL. But there was something that some way he wanted to present to me in session, right? But without that information, I would have never known that.
Yeah.
So it was something that I could bring in and talk about.
You know, that is a perfect lead into what I was going to sort of finish on here. I've talked to so many health professionals, whether it's a low-level professional with a certification or the highest level professional with doctorates. And it seems like the fix, everyone says in some sense, is exactly what you said. We need a collaborative process where you have a physical therapist and a personal trainer and a psychiatrist and a general pediatrician, and all these people working in concert with one another and their individual patients. And I think the problem with that is obviously is insurance. There's a burn and churn thing going on. The more people I can see.
And it's HIPAA. It's HIPAA.
It's
It's confidentiality. So let's say like someone signed up with you, Steve, Monday, Wednesday, Friday, 6 a.m.
Yeah.
And then they only show up Mondays and Wednesdays. And then they never show up Mondays because maybe whatever's going on the weekend. You imagine if you could be like, hey, just so you know, this person was showing up 3 days a week, and then it went to 2, and now it's at none. Like what pertinent information that would be.
I mean, to keep somebody accountable and somebody who potentially, let's say, is on medications where they have an issue, a mental health issue, that would be very important for all parties, right? Including the person themselves. Yes. So I do think it's a problem, and it's also a problem because I would learn so much more if I was allowed to collaborate with people who are upstream of me, right? And because I can't collaborate with people upstream of me, then I don't learn as much. Now we can, as personal trainers, we're usually networked with like a physical therapist and maybe like an orthopedic doctor. So now I can't call the orthopedic doctor and tell them what's going on, or he can't call me and tell me what's going on with the patient without them releasing stuff. But I can call him to say, hey, I'm working with one of your patients. I know that you did this surgery. Do you think it would be okay if I do X, Y, and Z exercises? She's only, 2 months post-op. And then they can give me information like, nah, I would stay away from that because I don't think the healing is done yet. So
amazing for you to know, right? Yeah. And especially under the assumption that we're all here with the patient's best interest in mind. That's it, right?
That's it.
So if we have that assumption, one would hope that our communication would just be seen as such.
No, you say it's HIPAA, and I'm not disagreeing with you. I'm sure part of it is HIPAA, if not the vast majority of HIPAA. But I see the other part of it is just that these other physicians sometimes don't have time. So like if you're a psychiatrist, you might be seeing 24 people a day or something, right? Or so many people a day, and you're backed up and you have so much to do. So like they don't feel like like they're not getting paid to like contact you and then or contact me and like work collaboratively. Like they're overworked, and I feel like that's another issue, is that
Certainly
there's
a problem.
There needs to be, I don't know how this works, but there needs to be more of these jobs, because it seems like I mean, you can go online right now, and if you're looking for a physician job, there's thousands of physician jobs all over the place. There's just not enough physicians right now to fill them.
Wow.
So
It's unfortunate. I really hope that there's some change there.
Yeah. So let's end here. I want you to tell the audience how they can find more about you and what you do, and if they want to contact you directly or just follow you on the socials, how best to reach you.
Yeah, thanks. Dr. Blair, DRBLAIR, PsyD. So it's PSYD.com. Find me. I'm there. I do have a small private practice. I just started with a group of called PH Wellness, which is a personal trainer. Another guy who is able to hire something like 200 people a year with criminal records. So a treatment center that is designed around incorporating physical fitness and job placement, which is huge, because some people get their life together and then are stuck due to some poor decisions they made in the past.
Sure.
So I'm working to develop their curriculum. I am around. I am on social media as well. Dr. Blair PsyD on Instagram. At your service.
Well, we'll have to do this again sometime. We'll pick out another topic. Maybe when you start working there, you can come report back on how that process goes, because it seems very unique. I've never heard of that sort of collaboration.
It is. These guys have a vision and they are so excited. One of the guys, Tony Hoffman, was a BMX athlete who Olympic athlete, and was became addicted to heroin and was in jail for 2 years, sober ever since, and is now totally motivated to tell a story and to help others get back on track.
Well, can't wait to have you back on to talk about that. This has been great information. Thanks for joining the
My
TrulyFit
pleasure.
podcast.
Thanks for inviting me on. Great to see you.